My name is Dr. Tamika McGee-Rogers, and I would like to thank you all for joining us for today for the Global Alzheimer's Platform Foundation DEI webinar on race and ethnicity data. I serve as the Associate Director of Recruitment and Strategic Initiatives for the Global Alzheimer's Platform Foundation. We have a network of over 100 clinical research partners across the world that collaborate to speed the delivery of Alzheimer's and Parkinson's disease treatments, lowering the cost and duration of clinical trials with a commitment to promoting diversity in clinical research to ensure that no one is left behind. In February of 2022, we launched our Inclusive Research Initiative, which is an expansive diversity and inclusion program aimed at substantially increasing representation of racially and ethnically minoritized communities in clinical research trials through cultural tailored recruitment and retention practices across North America. With a focus on relationships and education, the initiative seeks to establish relationships with GapNet sites and their community members built on trust, understanding, and unification with our programs and resources through support from community partner connectors, a mobile research unit, and the GAP IRI Advisory Committee. By being intentional, GAP IRI wants to ensure that representation in neurodegenerative research is not an afterthought, but a priority that is laid into the foundation and formation of every GAP-enabled clinical trial. Our previous DEI webinars have focused on health literacy, confronting unconscious bias, and building cultural competency, and the importance of having diverse participants as well as a diverse workforce. Today's focus on race and ethnicity data is not only an important topic to discuss, but highlights the need for sites and sponsors to collect race and ethnicity to ensure therapies and interventions for Alzheimer's and Parkinson's disease work for all. I would like to hand it over to my colleague, Janay Austin Todd, to provide more information about today's speaker.
Thank you so much, Dr. McGee-Rogers, and thank you everyone for joining us for the first GapNet webinar in a series on race and ethnicity data in clinical trials. Through this series, we will explore the concepts and their role in health equity, strategies for data collection, and the FDA's guidance on diversity plans in clinical trials. Today, we are honored to be joined by Dr. Joyce or Joy Balls-Berry. Dr. Balls-Berry is an associate professor of neurology at WashU School of Medicine and core leader for the newly established Health Disparities and Equity Core in the Knight ADRC. Co-directors John C. Morris, MD, and David M. Holtzman, MD. Prior to joining Washington University School of Medicine, Dr. Balls-Berry was an assistant professor of epidemiology and senior associate consultant at Mayo Clinic College of Medicine and Science. She completed her formal education at Xavier University of Louisiana with graduate training at Washington University School of Medicine and the University of Toledo. Dr. Balls-Berry completed a postdoc research fellowship in health equity, epidemiology, and biostatistics at the University of Florida. Her work as a scientist centers on increasing awareness of the importance of community patient engagement and research to increase health equity in minority and under-resourced communities. Recently, she completed a PCORI project to expand the efforts of the Minority Women in Research Network, which she established in 2011. The network's mission is to promote community patient engagement and research conducted by minority women scientists interested in research collaborations, academic scholarship, innovation, and dissemination. As an educator, Dr. Balls-Berry received the Mayo Clinic Teacher of the Year Award for the Graduate School and Educator of the Year for the Center for Clinical and Translational Science. The faculty and the student body vote on these awards, and recently she also shared her story of living with dyslexia and handling personal challenges as a TEDx talk, which we will happily share. So welcome, Dr. Balls-Berry, and I will hand it over to you.
Thank you so much to both of you for the gracious introduction and invitation to be here today. Thank you for my team, for my research lab, for also joining us today. And thank you for each of you for taking time. So let's see if I can get this technology to work. So sometimes you think we've been on Zoom all these years that things will work. So we're gonna try this, and hopefully you all will be able to see my slides? And can you see my slides?
We can. We can
Okay.
see you and hear you and see your slides. Thank you so much.
Okay, great. All right, so being mindful of your time today, I'm going to be giving part one of the DEI webinar on race, ethnicity, and data. These are my disclosures. I'm happy to discuss any of my disclosures after the webinar today, obviously, since we're recording, and I welcome any insight others might have. So our learning objectives for today is that I'm going to give a review of some of the epidemiology as it relates to Alzheimer's disease and related dementia. And I am using the acronym ADRD on most of my slides. I'll discuss some of the social determinants of health experienced by African Americans who are at risk for a diagnosis of Alzheimer's disease and related dementia. And then we will determine some actionable steps to increase health equity. Keep in mind that some of the terms that I will use and the stories that I will tell may spark triggers for some people. I do not shy away from talking about constructs of race, racism, and other forms of discrimination, because as a woman of color, some of these experiences have been mine. And I've recently lost my mother, who I caregived for as well, in the context of her navigating health equity as well. So some of this is very personal for me as well. So I'm going to start with a quote from the poet and author Audre Lorde. And she said, "In our world, divide and conquer must become define and empower." So I want to empower each of you to continue doing this good work, to continue listening to the stories, and to continue to be prepared for the hard and difficult conversations that might come about as we're thinking about health equity, health literacy, social determinants of health, in the context of clinical trial readiness and opening the doors for the voiceless. Our time is now. So we're going to start off with some review of concepts and some nomenclature. So health disparities and health equity are often used as keywords, and sometimes are even used interchangeably. And I want us to think about it in terms of the fact that it relates to global dynamics, it relates to education, media, often levels of privilege, and even the ways that we are inclusive of others and make them feel belonged, or even us feeling as that we belong. It goes back to health promotion, and even links to not only equality, but equity. And that's us having the resources that we need for ourselves and for those that we care about for overall wellness. And what my husband might need is a man who is 6'3", and what I need as a Black woman that's 5 feet tall might be quite different, based on our health, based on our genetics, based on family history, based on our own behaviors that we do to live and achieve wellness. So the term health disparities and health equity are often used, and you'll see in the United States, a bulk of our literature will use the term health disparities, but some of the international literature will use the term health inequalities. These terms do not refer to all differences in health, but rather it looks at the relative differences as it relates to specific differences in health. And this can be our behaviors, it could be influenced by healthcare policy, it could also be other factors related to the cultural aspects of wellness and quality of life. So when we think about comparing and measuring health disparities, the Rockefeller Foundation came up with 5 steps to measure health disparities. And they wanted us to keep in mind that we often we need to define our measure. What are we looking at? And then which group are we comparing comparing the differences to? So we always have to have a comparison group. And oftentimes comparing inequalities between groups can also cause victim blaming for groups who are not the referent group. So there's some statisticians and epidemiologists. I'm an epidemiologist by training. We're thinking about this in context of often in the United States, our referent group are white Americans. And is that the right group for all research studies? Why aren't we using other groups for comparison? And then if we make certain comparisons and certain inferences from data, how does that relate to absolute and relative differences in even health status? And are there different weights that are applied? Like, are we oversampling for certain communities because we feel like their voice needs to be heard? Are we recruiting too many people from one group, which means that the study findings cannot be generalized to other populations that might be at risk? In 2002, a report came out called Unequal Treatment. In this report, they found that evidence-based guidelines that should promote consistency and equity in healthcare were pivotal, and that the structured pay system was important to guarantee that historically minoritized patients were receiving adequate care and that they were being charged an appropriate rate based on the rates that were being charged for others, which also goes back to insurance and things like that as well. And that even trusted communication between the healthcare team and their patients was also pivotal. Language interpretation services were important in terms of thinking about people that may have English as a second, third, or even fourth language. And then using community health workers or pomodoros to help patients navigate the healthcare system was also pivotal. When we hear these things, and we know that it's been years since this original report came out, a committee has just been formed to start reevaluating and looking to see if these guidelines need to change or be updated based on current assessment of the U.S. health system. So more to come. So when we think about health disparities, it's also important, especially in the context of race and racism and diversity, equity, inclusion. We also want to think about the levels of prevention: primary, secondary, and tertiary. Primary prevention is the avoidance of disease. It's removing the risk factors. In this case, it's often thinking about the constructs of racism that impact social determinants of health, and how do we address racism and systems and structures that have been in place to separate communities. Secondary prevention is thinking about screening, it's early detection, the prevention of the progression of disease should someone test positive for something or be found to have risk factors for those disease. And tertiary prevention is reducing disease complication and even thinking about long-term care for someone that might have a disease. As we move forward in our lecture today and in this webinar, another concept that I like to keep in mind is the concept of social determinants of health. These are unfair and avoidable differences in and within groups, within and between groups, communities, and populations. They are non-medical factors that influence health outcomes. They are related to conditions of where we are born, where we grew up, where we work, where we live, our age, and plus the systems and structures that shape the conditions of our daily lives. It relates to economic policies, the systems that are in place, the agendas that are set, the social and cultural norms, the social policies, and even political systems. And we think about this, especially in countries at all levels of income, health and illness, they follow a different indexes and societal gradients. where often that persons that live in lower socioeconomic positions tend to have worse health. We see this also in the United States when we look at race and racism. When we control for socioeconomic status and education level, we found that persons of color, so African American persons, also people of other of color as well, multiracial and the like, often have worse health conditions based on some of the social political constructs that have been put into place. So with that being said, we must think about race in the United States. Race, ethnicity, and racialization, racism all impact health, just like genetics, society, culture, and other aspects of how we live, where we grow up, and our ability to have the resources that we need to be healthy. So in terms of race and ethnicity, they're often used interchangeably, but that is not appropriate because they are different terms. Race is a social construct, and ethnicity relates to cultural identity, and neither of these terms are linked to genetics. Francis Collin, who was previously the head of the National Institutes of Health, really became famous for the Human Genome Project. And I really like this historical statement from 2004, where he said, "A true understanding of disease risk requires a thorough examination of root causes. Race and ethnicity are poorly defined terms that serve as flawed surrogates for multiple environmental and genetic factors in disease causation, including ancestral, geographic origins, socioeconomic status, education, and access to healthcare." Keeping that in mind, if we know that race and ethnicity are flawed, but yet we do see differences in terms of health equity as it relates to different races. So this comes into mind that we need to consider the current races that we have in the United States according to the US Census. And there are 5: American Indian or Alaska Native, Asian, Black or African American, which includes all those who self-identify across the African diaspora, Native Hawaiian, or Pacific Islander or white. And then the current ethnicity is Hispanic or non-Hispanic, and you'll also see on some forms Latin, Latina, Latino, and Latinx as well. So why do we measure health disparities by race, ethnicity, and socioeconomic status? Government agencies and insurance companies measure health disparities to determine new interventions and ways of increasing wellness. We know that race and ethnic health disparities exist even when socioeconomic status is controlled. We know that differences in healthcare may be related to socioeconomic status and socioeconomic inequality, as well as race and ethnicity. Stereotypes, bias, prejudice, and even clinical uncertainty by healthcare team members may add to racial and ethnic disparities. So some research suggests that racial and ethnic minoritized patients may not seek treatment based on the prejudice and stereotypes and discrimination they may have experienced or those around them have experienced. So when we think about the epidemiology of Alzheimer's disease, a lot of my work is with the African American community. So some of the information that I will be providing today relates directly to African Americans. So we know that and I will be interchanging the term Black with African American, because we also know that our African Caribbean friends and colleagues and brothers and sisters, and even those that are from other parts of Africa are grouped within the context of the African diaspora. So non-Hispanic Blacks and Hispanic older adults are more likely to have an Alzheimer's disease, Alzheimer's and related dementia diagnosis than our white counterparts. There's also small differences when we look at the biomarker data as well that appears to be stronger for white Americans than Black Americans. However, race is a social construct and not genetic, and while the disease is more prevalent in the Black community. We also know that Medicare recipients who are 65 and older are often diagnosed with Alzheimer's disease and related dementia more in Black older adults than other communities. The second group with the highest diagnosis is Hispanic or Latin community members, followed by white Americans. So the burden for dementia and Alzheimer's disease and related dementia is highest among Black and Hispanic older adults than among white older adults. So that brings us to a quote from Desmond Tutu. He said, "My humanity is bound to yours, but we can only be human together." So we do have some opportunities to address social determinants of health that are experienced by African Americans and other minoritized community members. This means that we need to start thinking about the timeline of racism in science. In the 1700s, the first description of race in man was published in 1759, called The System of Nature. And during that same period, leading in before the 1800s, there was even the development of the facial angle formula, which looked at different statues and things like that. And then later on, an anthropologist defined the 5 races of man. In the early 1800s, the cranioscope theory became named. And then we also see during that same timeline that during that timeline, there was linkages between racial comparisons and phrenology. And I am dyslexic, so I might say something a little kind of off, but just know it's chalk it up to my brain naturally, literally, not my heart. And so in the 1830s, there were more things that were happening here in the US, in New York, specifically in the Pharmacological Cabinet, which was in downtown Manhattan. As time went on in the early 1900s, eugenics became a play. And then as recently as the 2000s, there was even an argument for race-based science. So all of these things have an impact on how we study data, how we look at data, and how data is interpreted, and how certain communities are often marginalized based on our race, and also how care is provided to different communities, where care is given, where are there care deserts in terms of there not being hospitals in communities that need them most, and the like. So racialization is a factor that we really should be discussing when we also are talking in the constructs of racism. In the Human Genome Project, they recognized that genetic characteristics were important, as well as the geographic origins of our ancestors, which is not race, and that there is a predisposition of many groups based on the social construct of race, where those communities experiences more disparities in health. For instance, we are often characterized by how we look, our hair textures, our skin tone, our facial features, and even the dialects in which we use. Racialized groups have often have different experiences, as well as those transgenerational histories of slavery, immigration, genocide, as well as acculturation, which puts us at greater levels for different health outcomes. And these levels have been altered across generations because of racialization. When we think about the epidemiology of Alzheimer's disease, this map comes directly from the Facts and Figures report from the Alzheimer's Association. And as you look at this map, you can see that there are certain communities that have greater risk for Alzheimer's disease. And I'm sure if we started diving into groups within those communities that are at greatest risk, we'll find that racialized groups within those communities have the greatest risk factors for Alzheimer's disease and related dementia, followed by those that have differences in social and lower socioeconomic status based on education, income, or even job type or education level for that matter. In the 2021 report from the Alzheimer's Association, I really liked this graph, which was their figure 19, which looks at access to healthcare providers who understand racial and ethnic backgrounds. And so the darker color is whether or not it was important for Alzheimer's and dementia healthcare providers to understand race and ethnicity of the patient. And then the lighter blue is whether or not they were confident, if patients were confident that currently have access to a provider who understands their ethnic or racial background. And you can see from here that African Americans, as well as Asian and Native Americans and Hispanic Americans, all felt that it was important that their providers understood the concept of race and ethnicity as related to them as a patient, but they weren't fully confident that all of their providers would understand the concepts for them personally. So this is a framework on structural racism that was created by colleagues back in 2022. And they wanted to look at structural racism and discrimination. And they defined this as micro levels of conditions that limit opportunities, resources, and well-being and lived well-being of less privileged groups. They wanted to also link the comorbid health conditions that are often found with patients who are diagnosed with Alzheimer's disease and related dementia, like hypertension, diabetes, obesity, as well as depression. And they looked at the historical impacts of structural racism and discrimination, and they included discriminatory practices related to housing policies, which resulted in segregation related to residential segregation that has been shown to limit education, employment, as well as healthcare. They also wanted to examine these characteristics, especially as related to Black and Latin communities and populations who are at risk for Alzheimer's disease directly or even indirectly, and the negative impact that systematic and structural racism and discrimination played on these communities in terms of access to quality and cost of healthcare. So from this study, they found that there was no standard approach for measuring social determinants of health. And this is why they wanted to create this particular framework. So if we look at the first box on the left, we can see that the investigators from this particular study wanted to look at policies, practices, and social political constructs. They wanted to examine the institutionalized racism, as well as social determinants of health and system-level barriers in healthcare. So they wanted to look at things related to reimbursement status, accessibility, workforce training, community investment, and even resiliency. And then they wanted to look at the care condition and how this information exchange would happen between public health through different workforce trainings, as well as levels of engagement. And then they followed up on the right side of this particular figure, looking at the the social determinants of health that were interpersonal, those experiences that the patient had themselves, as well as the interpersonal level, so their loved ones or the people that they care about, and things like related to biases, discrimination, perceived and actual discrimination, and even examining the everyday discrimination that might occur. And they also wanted to look at healthcare, their social needs, even stigma, and even language and cultural differences. And this related overall, by addressing this, they wanted to look at patient-centered care, patient levels of engagement, case management, and even cultural competency training of healthcare teams. Overall, patients with Alzheimer's disease, they found that there were several risk factors, which we stated earlier, like heart disease and hypertension and diabetes and the like. And they also wanted to make sure that timely and improved quality of care would reduce costs through reduce costs and provide improved quality of life by increasing health equity. So keeping this framework in mind allows us to really think about the intersection of how our social constructs play a role in our ability to receive the care that we need, and especially for patients who are at risk for or diagnosed with Alzheimer's disease and related dementia. So interpersonal and institutional racism was associated with lower memory scores in many multiracial groups. There were multiple studies done that evaluated experience at the interpersonal level, so the individual level, and looked at institutional racism and the construct of being able to receive the care that one needs. Structural racism was also played a role, with African Americans or Blacks noting that they've had more experiences exposure to structural racism. Yet all groups in this one study, in this particular study, had 1,000 middle-aged adults who reported experienced interpersonal and institutional racism, and that was associated with their lower memory scores. And those that experienced structural racism had lower episodic memory among all racial and ethnic groups that were included in the study. And in another study of 445 Asian, Black, Latin, white, and multiracial groups who were over 90, individuals who experienced a variety of discrimination, including racism and other types of discrimination throughout life, had lower somatic memory in late life compared to those who reported not experiencing discrimination. So we know that lifetime's experiences with racism and other forms of discrimination can impact weathering, and that it can impact somatic memory across our lifetime. So what about St. Louis? So St. Louis is my hometown. I grew up here, and I moved back after being away for almost 19 years. And the beauty in coming back home is that I was able to see growth in some areas where health equity was being discussed and being looked at, and policies were being put into place to address it, but then see other communities that were still experiencing health disparities as well. So a large portion of our community is African American, and this community is growing. And St. Louis is in the Midwest. We do deal with systemic, structural, and systematic issues that are often compounded because of the consequences of slavery, Jim Crow rules, redlining, which relates directly to residential segregation and other forms of discrimination. One of the things that I've been really interested in is looking at the locations of hospitals and healthcare clinics, and if they're located in communities that have people of color. And many of those communities have food deserts, healthcare desert, limited transportation, and limited job options. And this all impacts the quality of life of those that live in those communities. So a group of my colleagues, led by Suzanne Schindler, we sought to look at the usage of our memory and aging clinic, which is the clinic that patients come to receive diagnosis of Alzheimer's disease and related dementia and diseases on that spectrum. When we compared Black and white patients, we found that there were more likely to be delays in diagnosis when a patient was Black. There was lower usage of the memory clinic of those who was actually lower for communities of color, especially for Black patients compared to our white counterparts. Black patients came in with more advanced dementia, and most of the drugs that were being approved were not used in clinical trials. That most of the drugs being approved did not include Black patients in those trials. So, so that, or if they did, it was a lower number of Black or patients of color, which means that the findings could not necessarily be generalizable to those communities. So Dr. Maya Angelou stated, "Prejudice is the burden that confuses the past, threatens the future, and renders the present inaccessible." And this is true when we think about the willingness we have to determine actionable steps to increase health equity, especially in the construct of examining racialization, racism, and trying to figure out what do we need to do to dismantle systems that have further separated communities from the care that they need, and even the ability to participate in clinical trials for us to do more disease prevention for Alzheimer's disease and related dementia. So we measure race as a factor. We also have talked about the fact that we need to think about those stereotypes and biases that have been put into place. But that also means thinking about microaggressions and the power that lies with them. So this quote here comes from Sue, and Dr. Sue is one of the most sought after thought leaders that have examined microaggressions and power. And he stated, "The power of microaggression lies in the invisible to the perpetrator." So that is the person doing the microaggression, who is unaware that he or she or they has engaged in a behavior that threatens or demeans the recipient, so the person receiving the message of such a communication. And there are three main types of microaggressions. So microassaults, and this is similar and traditional racism. So as an African-American woman, when I moved back to my hometown, I'll give you an example from my lived experience. My husband and I moved back in 2020, in July of 2020, in June of 2020 to St. Louis from Minnesota. He and I decided to go out for a walk, and this was in the throes of the COVID pandemic. And we was like, oh, we'll go out and walk outside by the largest park in the city. Someone drove down the street, rolled down their window, and called us a racial slur. That is an example of a micro assault. A micro insult could be seated in an undesirable location at a restaurant, like next to the kitchen. It could be it could be the wait staff not refilling your water, but refilling if you're a person of color, or if you're a woman, but refilling the water of all the men. A micro invalidation is making assumptions about someone. So for instance, a person could say, have said to me, would you like for me to draw a picture or a diagram for you? Because I know you're dyslexic and I'm not sure if you can read this information. That is a micro invalidation. So we have to think about diversity in healthcare and think about the people that we are hiring and what that workforce looks like, because many times participants of color often prefer healthcare providers who relate to their lived experiences as people of color. Often historically minoritized patients wanted someone that could understand their ethnic or racial background, who had their own experiences with discrimination, and that it was not surprising that many non-white racial and ethnic populations also feel it is important for Alzheimer's disease and related dementia care providers to be more culturally competent. So there have been surveys that have been done of patients and with living with dementia and their caregivers, and they really wanted someone to have their care team to have providers who understand different racial and ethnic backgrounds. They also wanted to make sure that these providers were willing to have tough conversation. And so, keeping that in mind, I've also found that even in my research, we've asked our participants questions like, is it important that the researcher conducting studies in your hometown or with your community, do you want them to come from your community? And they say yes. And then the question becomes up, well, how do we get them into the workforce? So this quote here is from Crenshaw, who coined the term intersectionality. And she stated that systems of inequality based on gender, race, ethnicity, sexual orientation, gender identity, disability, class, and other forms of discrimination intersect to create unique dynamics and effect. If we take all of those things and we compound it with a complex health condition, then we know that we've got more work to do in terms of preventing Alzheimer's disease and dementia, early detection with different types of biomarkers, making sure that the drugs and other interventions that are developed are useful for diverse communities, and ensuring that caregivers and support members also have the resources that they need to help the patient navigate this new journey. So the Knight Alzheimer's Disease Research Center, previously under the direction of Dr. John Morris, Dr. Morris is now the co-director, with Dave Holtzman being the lead director. Under Dr. Morris's leadership, we created and established the Health Disparities and Equity Core. Underneath that core, we decided that we really wanted to focus on three main issues: community and patient engagement and research, in terms of thinking about sustainable research partnerships with community members, community-based organization, other faith-based groups, and non-traditional partners in the Alzheimer's disease research space. We also wanted to develop a plan to increase diversity of the Knight Alzheimer's Disease Research Center's workforce. And we sought to secure funding from the National Institutes of Health and the National Institute of Aging to increase diversity in Alzheimer's disease-related research. So from that, I applied for an R24 grant, and we did receive funding. And the name of the grant is, the name of our study is Co-Equal. And the goal is to create a research registry that is diverse, that is reflective and representative of our community and those at greatest risk for developing a diagnosis of Alzheimer's disease and related dementia. So Co-Equal is one word, and we use it as an acronym for creating opportunities to increase health equity and equality for persons at risk for Alzheimer's disease and related dementia. As we started this project, we had three main aims. Our first aim was to conduct a community needs assessment. We used a scientific cafe model that we call brain aging cafes, and I've selected a few quotes from the cafes. We had over 306 community members participate in the cafes, and they were held in diverse settings around St. Louis, including apartment buildings that had common spaces, community-based organizations that provided youth and family services, also in different faith-based communities as well. So we asked a variety of questions about research participation, their thoughts on Alzheimer's disease and related dementia, and things related to trust often came up as it related to research participation. And as you see from the first quote, is I'm always drawn to participating in some way because Black people don't participate, and disproportionate rates due to previous events in our history that broke trust. I always like to be a part of it in its research because I want to help to give back to the Black community. They don't have as much data on us, and since we don't participate as much. And another participant stated, due to past experiences that took advantage of Black people, people are weary of participating in research. And most of this was stated in context of not only the Tuskegee experiment of untreated syphilis in the Negro male, but also the Cold War experiments that happened in St. Louis, Missouri, which many of our participants were aware of. So a while ago in 2022, some colleagues and I wrote a paper looking at the intersection of identity and health. And we looked at a variety of domains, especially in aspects of individuals' identity, our genetics, and even our lived experiences, which are impounded and impacted by cultural and structural and social determinants of health that interact to influence aging and Alzheimer's disease and related dementia. So these are things like societal stressors that can be real or perceived, the social support that we have, and then the things in the smaller box, I'm on the left side of the table of the figure, our education and health literacy, the jobs that we have, so our occupation, and even the positions that we have in our social and cultural groups. The social and built environments and even the neighborhoods in which we live in, our social identity, and even access to quality of healthcare, which impacts health disparities in Alzheimer's disease and related dementia outcomes. That smaller box really relates to our education, the years of education, the quality of it, and the amount, which then impacts the types of occupations that we have. So these impact overall our conditions of daily living and then the social economic position that we have. And overall, all of that impacts our ability to have health equity, which compounds our risk factors for health disparities. The prior director of the CDC stated, confronting the impact of racism will not be easy. So none of this is easy. So with that, a couple of final thoughts. The time is now. We must acknowledge that disparities exist. We must not have fear in discussing the historical underpinning of science that marginalize people, especially people of color. We must consider data analysis and interpretation in healthcare data with healthcare data and the context of racism. And we must determine ways that our programs can increase health equity. So I'm going to leave you with my own quote. Being seen, heard, believed, plus acknowledging racism helps us to build bridges to repair the pain that many of us experience related to our identities and truths. Please feel free to reach out to me. My contact information is here, as well as the direct phone number to my research lab. And again, I look forward to your questions in the coming future. Thank you again for your time, and please continue to empower others. Please continue to stand on the forefront to increase health equity. Thank you.